That'll come to me.
And it's changed. There were, because there were cruise boats that changed. So the entire government and paying stuff. They love because they love luxury goods and they love the government. So it's really money and they travel. That was 5 years ago. Yeah, it's just wonderful.
You're going to have a healthy cigarette smoke thrown in there. That was beautiful. I love
Oh, really?
Yeah.
So I saw.
Okay. Right, okay, no.
Yeah. So there's only one series that's weight.
Okay.
I read some of it and I'm not sure they're thinking I'll be late.
General knowledge, mainly neurology, so neurology is
Can I do that? I think
Oh, okay. We have had an outbreak in our hospital, so I guess
So you were okay with that?
What role do I play? I'm a wife, I'm a mother to 4 children. I'm also a carer to my husband who has hereditary amyloidosis. He was diagnosed in 2013. And since then, a lot has happened, which led me to start an association for amyloidosis patients in New Zealand. So NZAPA was formed at the end of 2019, New Zealand Amyloidosis Patient Association. Who do we support? We support patients and carers, first and foremost. Our motto is, we are better together. And what we do, there's a lot of information out there for somebody that's just been diagnosed with the disease, so it's important that you get the most up-to-date and correct information on the disease. So we provide that. We provide treatment information as well. There's a lot of treatment currently being done in the market globally, which is fantastic for patients that, especially for the wild type and the hereditary, which at this point in time, as we know, there is no cure. So providing correct treatment advice and information is very, very important. And further to that, once you think that you're not feeling well and you go to the doctors, generally you will not be able to get a proper diagnosis at that point. So what we try to do is to connect patients with the correct specialists that know what this disease is about. So we connect patients with the specialists either locally or overseas. Further to that as well, which is equally important, is we connect patients to patients, because at the end of the day, I think supporting one another is so important. Even carers, because I myself am a carer, and initially when my husband was first diagnosed, it was very, very difficult to come to terms with what was happening. And I remember wishing almost that I had somebody there that I could talk to and get advice from. So taking into account what we have gone through as a couple, we want to be able to provide this sort of connection between patients and carers with other patients and carers, because, again, as I said, support is really, really important. So what have we achieved since the start of NZAPA? We have placed New Zealand on the treatment map for a lot of pharmaceutical companies. Prior to us starting the association, New Zealand almost is not on the radar for a lot of these treatment entities. So now that we have this association, we are really, really proud, because we are now on the world map, and clinicians overseas and pharmaceutical companies now realize that, hey, we do have Kiwis who are suffering from this disease, so we need to also extend our support and treatment to this country. So we've done that, which is great. We also advocate for disease awareness. As I mentioned, a lot of doctors actually are not aware when they diagnose patients to take into account amyloidosis. So advocating for disease awareness and education is very, very important, not only to the patients themselves, but I think equally important to the practitioners, pharmacy people, even students in the medical profession. I think it's important that they learn the features of this disease, so that when they eventually see a patient who has it, they won't waste time trying to figure out what it is. Right away, they'll take into account that, hey, it may be amyloidosis. I'm also proud that we're able to conduct workshops and conferences that will be held annually.
Welcome everybody. Can you hear me?
Yes. Yep.
It's a bit embarrassing seeing myself on the slide. On behalf of New Zealand Amyloidosis Patient Association and Board of Trustees, welcome to all patients, their whānau, and to the healthcare professionals attending this evening. A warm welcome also goes out to our online visitors from different parts of the world. Thank you for taking the time to visit with us for this very important conference. We are all in this journey together. This evening, I want to also use this opportunity to honor the patients who for many years have suffered bravely in silence with this diabolical disease. Many still continue to face this battle bravely with little or no hope for recovery. This year itself, we have seen 3 people pass away. The situation must change. The impact of having amyloidosis is far-reaching. The nature of this condition not only robs the sufferer from having a good quality life, but also precious time together with loved ones. Amyloidosis is like a road-raging truck on life's highway. This heinous vehicle rear-ends everything and everyone that gets in the way into the ditch, leaving only carnage behind. This plight has to stop. We are very blessed to live in beautiful Aotearoa. New Zealand is the first country in the world for the sun to shine on as it rises. Unfortunately, we are also one of the last places among other OECD countries to feel the warmth of rare condition medicine treatment. The only way that we can shift this pendulum is by coming together, patients, caregivers, and clinicians, so we can make a positive difference and impact change. So this evening we sit or stand next to each other to not just learn more about amyloidosis, but equally important, I want you to realize that you are not alone, that you matter, that your voice is important, and that change can happen. My prayer is that as we leave this conference, after all is said and done, more empowered and encouraged. Thank you. I would like to introduce our esteemed speakers. Flown in all the way from Brisbane is Dr. Peter Mollee. Dr. Mollee holds many credentials, but to save time and hopefully do him justice, I will introduce him as a hematologist and director of Princess Alexandria Hospital Amyloidosis Center. Dr. Mollee is also at the forefront of systemic amyloidosis diagnosis techniques in Australia. Even more endearing is that he is married to a Kiwi, which makes him heartless. Coming to us via online stream is Dr. Simon Gibbs, who is feeling really sad that he's unable to be here in person thanks to COVID-19 in Melbourne. Dr. Gibbs is a consultant hematologist and amyloidosis lead at the Department of Clinical Hematologist Eastern Health, director of the Victorian and Tasmanian Amyloidosis Service, a founding member of the Australian Amyloidosis Network, and honorary senior lecturer at Monash University. We want this evening to be all about you. We will have a question and answer session after their presentation, so please feel free to ask away afterwards. The only stupid question is a question that is never asked. Gentlemen, the floor is yours. Dr. Mollee, are you presenting first?
No,
Simon's going first. Okay.
Can you hear me?
Good to go.
Am I on?
Yes.
People hear me?
Yes, we hear you.
Can you hear us, Simon?
We hear you.
Fantastic. Well, thanks very much everyone for asking me to present to this exciting workshop. I am extremely sorry that I can't be there. I would have loved to have been there and seen you all. I can't see any of you here, and I can't seem to share my slides at the moment. I think, Matt, if you allow me to share my slides, I can start. But yeah, very sorry that I can't be there. I'm sure it's not an anti-Victorian thing. Remember, Scott Morrison is actually from New South Wales, not from Victoria, and I apologise for our Prime Minister, and I've said this to several New Zealanders on many occasions actually, that we're very happy to swap leaders at any time. Let me see if I can share my screen now. All this looks promising.
Yeah.
Right. Can people see that?
Yes.
Fantastic. So I've been asked to talk about what is amyloidosis, and in particular talk about ATTR and go over some of the treatments. So first of all, what is amyloidosis? Well, basically amyloidosis is kinky proteins. Anyone with amyloid have got proteins that are a bit kinky. So they are proteins that misfold and then stick together and make a very hard wax-like substance, almost like concrete. And in fact, it comes from the Latin and the Greek meaning starch-like, so quite hard. So proteins themselves are small molecules that we all have, and they help life biological processes. So your genes will tell you to make proteins from amino acids, and these proteins will have all sorts of different roles in life, such as making antibodies as part of our immune system to fight infection, to produce hormones that regulate our body's growth and organ function. And it's the way that the proteins are folded is really quite important as to how well they are going to be able to do that function. And when they are folded properly, they work well. The problem with amyloidosis is when these proteins start to kink or misfold, and then they assemble abnormally. So when we look at amyloidosis, this hard wax that's made from misfolded proteins, it depends on which proteins have actually kinked in the first place to determine the type. And the type will often dictate which organs are involved and what treatments we need to use. So I'll be talking about the transthyretin types today. Regardless, what we often have as clinicians is that we're faced with a patient who comes in and says, I feel pretty rough. I've got vague symptoms like new breathlessness, I've got numb fingers and toes, I've got some weight loss of appetite, feel lightheaded. I mentioned the breathlessness, swollen legs. Or we might pick up that they've got some excess protein in the urine or an irregular heartbeat. So because these are common and vague symptoms, we don't often think about amyloidosis as our first cause. So often it will take some time for things to be delayed, and it can involve a number of different organs such as the kidneys, the heart, the nervous system, and the gastrointestinal tract. When we do make the diagnosis, we need to work out, is this amyloid just in one spot? Is it just a little bit of protein that's made from locally produced abnormal kinked proteins, or is it actually in the bloodstream that's circulating? So it's localized and systemic. Localized is pretty rare, but the prognosis is excellent and doesn't usually require any treatment. So it's really important that we distinguish between those two. And it can also be hereditary and acquired type. So acquired, it occurs spontaneously, often as we age, or hereditary is that we've inherited some faulty genes from our parents. And I mentioned that the type of amyloidosis will determine the prognosis and the treatment. So it's important that we work this out when we are first faced with a patient with amyloidosis. So I'm often asked, well, how common is this? Well, a lot of people say this is a rare condition. Peter Mollee, who's speaking after me, did a great study that looked at what the incidence in Australia seems to be. We think that probably about 300 Australians are diagnosed with AL amyloidosis every year. I'm sorry I don't have the New Zealand data on that, but we believe that up to 10,000 Australians have ATTR. This has been a really underdiagnosed condition, and it's only in the last couple of years that we've realised how common it actually is. Regardless of the type, we know that it is more common in adults aged over 50 years of age, and tragically it's more common in males. Symptoms are non-specific, as I mentioned, and so the diagnosis can be missed. And we know that there are certain risks that will mean that you're more likely to develop amyloidosis. So if your bone marrow, the body's factory for blood cells, produces too many immune light chains, then you may be at risk of having the AL form. We know that if you have a family history of amyloidosis, brothers, sisters, aunts, uncles, parents, then you're more likely to have it as well. If you have chronic infections or inflammatory autoimmune diseases, you're more likely to have the secondary AA type. And tragically, as we get older, we're all at risk of getting the ATTR. It does seem to be a disorder of aging. And I mentioned that as a consequence of increased awareness, we're actually seeing a significant increase in the diagnosis of ATTR, and that probably also reflects our aging population. And the diagnosis is delayed, and this is important, and I think some of you in the audience will probably only know this too well, that many of our patients will have symptoms for 1, 2, or even more than 3 years before they're actually diagnosed. And most patients will see more than 3 doctors before they actually get a diagnosis. And the diagnosing physician is often a hematologist, which reflects what I consider to be the more intelligent specialty within medicine. But I'm a bit biased. When we think a patient has amyloidosis, we often will take a biopsy fingertips. Insoluble configuration, which we call amyloid fibrils. It's a bit like having the 4-leaf clover can fall apart and the leaves can misfold and stick together. But when we look at treating, we're actually increasingly going back to the gene that's actually making the TTR in the first place. Can we actually stop the production of TTR? Do we actually need so much TTR in our system? And we can live perfectly well with 90% of our TTR not being there. So we know that we can knock this down. So what we try and do is we have these drugs called gene silencers. We try and turn the genes off, so we stop making the protein that makes the amyloid. And there's a number of trials that are going on, and some that have finished, which show that these molecules have great promise and seem to be highly effective and well tolerated. Then what we can actually do is that we can stabilise the 4-leaf clover so that the leaves don't fall off. So we call these TTR stabilisers. You may have heard of drugs such as diflunisal and tafamidis, and the new kid on the block is something called acoramidis or AG10, which I believe some of the New Zealand sites have actually had that trial open as well as Australia, and it looks very promising so far. We can also try and disrupt the fibrils, so when those misfolded proteins stick together, using doxycycline, which is an old antibiotic, and even green tea extract called EGCG. Lastly, the holy grail really is to try and take the amyloid out of the heart if we can. There is a potential treatment, but those trials seem to have been significantly delayed, which always spells a bit of trouble. But watch this space. We can attack this disease from various angles. So let's start with diflunisal. So diflunisal, it's an old anti-inflammatory drug. And but it was shown in a test tube that it can actually stabilise the 4-leaf clover and stop it from falling apart into individual units. And there was a trial at what called Cosigo double-blind study where half the patients got the real drug and half got the dummy drug, a sugar pill. And what that demonstrated is that patients who are on the diflunisal, they're on the anti-inflammatory TTR stabiliser, their nerve problems didn't progress as much, their quality of life didn't deteriorate as quickly, and in actual fact it was really quite well tolerated. So I always watch the kidney function, the blood tests, and because it can upset the stomach, I always take it with some food, and it's usually given twice a day. If we look at tafamidis, this is the one that's got all the press. So diflunisal costs $1 a day. I've had a patient in Australia who has been buying this privately and he's been paying $12. Have a look at a test tube. Compared to tafamidis and diflunisal and AG10, what's really interesting is that in actual fact tafamidis, there are reports that tafamidis is slightly weaker than diflunisal, despite the fact that it's got a much higher price tag. If we then have a look at AG10, that looks particularly beneficial. Patisseran I've mentioned, so Patisseran is the genes areas. We saw that there was stabilisation of cardiac function. It was, as I mentioned, very, very well tolerated. If you have a look, that there was double the number of patients on Patisseran than on placebo, and what we found was that the rate of death was better in the Patisseran than the placebo. Not thought to be due to the study drug. If we look at inotersen, which is a competitor agent, we also saw that there was a significantly a statistically significant difference between those at 8 months and 15 months. We saw that patients did not deteriorate as quickly on the inotersen, and that also equated to an improvement in quality of life as well. Doxycycline I'll just mention briefly. So this is an old antibiotic which definitely seems to. Green tea has been reported mainly by the Germans as potentially halting progression or slowing progression. You need to have the tablets because otherwise you need to drink 2 litres of the stuff every day. I wouldn't advise doing that. We've treated about 80 patients with this because it's cheap and easy to access. The only problem is it can cause some liver dysfunction in very high doses. So we don't recommend very high doses, just up to 600 milligrams. The other form of treatment I just wanted to touch on, which I think, again, as doctors, we do really badly at emphasising, and that is, the free stuff that you can do yourself. So the 3 Ds are the diet, diuretics, and daily weight. So the diet, low or no salt. Okay, diuretics and daily weight. So the diet, low or no salt. Okay, don't have it on the dining table, don't add it to food. Salt means you'll retain more fluid. You should be on a fluid restriction as well if you've got a lot of fluid retention, and to weigh yourself every morning if you're starting to do so, because patients will often complain that I'm not hungry, I don't have an appetite, I feel full already. So you might eat quite well at breakfast, but it's still sitting in your stomach by dinner time, so you don't feel like dinner. So domperidone helps to push food through the stomach, take it before meals, and often you find you'll be able to eat a little bit more. And maybe take some supplements like sustagen, so things that are easy to digest, so build up shakes, etc., etc. Speaking to your dietitian can help. If you have low blood pressure or dizziness upon standing, I think midodrine's a really good drug, and they can help boost up the blood pressure. And we've got lots and lots of different things for diarrhea. We can bind people up. We just need to be able to take enough, and people are scared to take too much. Also, dietary modifications are important. Obviously, caffeine can irritate the bowels from spicy food. So if you have diarrhea, back off on those. And we have a number of treatments for those who have cramping, nerve pains, etc. So please let the doctors know if you have these symptoms and insist that they be treated appropriately. Last but not least, I'd encourage any of you to check out the Australian Amyloidosis Network's website, which is amyloidosis.net.au. There's lots of different bits of information on there. And I think that this cartoon on YouTube called Amyloidosis Awareness is really, really helpful. It goes through some of the things that I've mentioned today. And also the Amyloidosis Research Consortium does some online booklets, which I think are really, really helpful. And I would ask you to check those out. But that's my presentation. I just want to again thank the organisers for asking me to speak, and I'm happy to answer any questions after Peter's talk. Thanks very much.
Thank you, Simon. I'm not sure whether you can hear me, but oh, hello, Simon. Everybody is very thankful and
hello.
Hello. Are you playing tag team with Peter then?
Yes, I think we're going to do questions at the end.
Yes. So I'm going to pass the microphone to Peter. Thank you, Dr. Mollee.
Thanks very much, and thanks for inviting me over here. It's my first trip outside Australia for a long time, so I've got another 2 days with no COVID cases in Auckland, and I can get back home safely. So no COVID in here, please. Okay, so I've been asked to talk about AL amyloidosis and A amyloidosis. Sorry, it's not working. What do I have to do? Turn it on? Turn it on. It's a trick. Okay. Next, please. Actually, we're going to go through, we skip through a few slides because Simon talked a little bit about what amyloid was. Keep going, keep going, keep going, keep going. Yeah, keep going, keep going, keep going, keep going. Okay. Okay. So, just a bit of indication, how many patients have AL amyloidosis or a carer for someone with AL? Okay. The kidneys, the liver, and the nerves are affected. Next one. So what are these light chains? I'll just spend a minute trying to explain this because it's technically a bit difficult. So light chains are part of what medically we call immunoglobulin, but what most people call antibodies. So this is what your immune system makes to fight off a virus, for example. And the way it works normally is that you get 2 of these heavy chains. These are proteins, heavy chain proteins. So your plasma cell makes 2 of these. It makes 2 light chains, and they assemble together to form the antibody. And what happens is that this end of the antibody is what recognizes the target, so say a virus, and this end is what attaches to one of your immune cells. And so what it does is it brings your immune killing cell right next to the virus and kills it. So that's how it works normally. Next one. So your plasma cells live in the bone marrow. This is kind of what they look like down the microscope. These little cells are blue in the, what we call the cytoplasm. And this little whitish area is the factory where all the antibodies are actually made. Next one. So in AL amyloidosis, these plasma cells grow into what we call a clone. They proliferate. Now each one makes normally a different type of antibody, but when you've got these proliferation of plasma cells, they're all making the same type of antibody. So they're all making this heavy chain and this light chain that forms into the antibody molecule. So it's all just one type. Next one. But what happens when your plasma cell is making these antibodies, it in fact always makes some light chains in excess to the heavy chain. So the heavy chains and the light chains join together to make this antibody, but there's always some light chains left over. And these are what we call free light chains, and there's 2 types, kappa or lambda. So in AL amyloidosis, the amyloid deposits can be made of either kappa light chains or lambda, not both in an individual, just one type. Next one. So this is a very confusing area, but I'll try and explain the association between the type of growth of plasma cells and whether the light chain itself causes amyloid or not. Now, if you've got a cancerous proliferation or malignant proliferation of plasma cells, it's making a light chain, but that light chain just circulates around the blood, doesn't cause any trouble at all, which is in fact most of the time. You've got multiple myeloma. If you've got a cancerous plasma cell, however, the light chain that it makes can misfold and form amyloid, then you've got multiple myeloma with AL amyloidosis. In the more common situation, and this is in fact in about, say, 5% of 70-year-olds, very common to have a proliferation of these plasma cells, makes a light chain, it circulates around the blood, doesn't cause any trouble at all, just pee it out. This has got a particular condition, NGUS. However, if that light chain, and this is the 10 per million type of situation, it misfolds and forms amyloid, then you've got AL amyloidosis. So you can have AL amyloidosis and underlying the plasma cell proliferation is not cancerous, that's the more common thing, but sometimes it is cancerous and you've got myeloma. Next one. So the symptoms are very varied, and it just depends on what organ's being infected. Simon's run through some of that. Next one. The presentation is often delayed. This is from our own clinic, 18 to 24 months of symptoms before someone's diagnosed. It's a problem. Maybe I won't run through these because Simon's gone through them. Next one. There's a couple of things that happen only in AL amyloidosis, tingling type symptoms, or the autonomic nerves. The diagnosis is based on a biopsy, so still at this time, it's impossible to make a secure diagnosis without a biopsy showing amyloidosis. Once you've found amyloidosis, you must prove that that amyloid is actually made of light chains. And this is key, as Simon mentioned, to managing patients with amyloidosis. The type determines the outcome, it determines the treatment. So if you haven't got the type right, you can't get those other things right. So it's absolutely critical. And there's a number of tests you can do to try and sort that out. And this is one of our main functions, in fact, of the Amyloidosis Network, is to provide the expertise to get that diagnosis right. In the majority of cases, it's not that difficult, but in a small number of cases, it's very difficult to work out what the type of amyloid is. Next one. So I'm just going to present on the way through a couple of cases that have come to us. Here's a 69-year-old man. He was found to have kidney impairment, so his kidneys weren't working properly. He had this thing called nephrotic syndrome, which is where he's losing a lot of protein into his urine, ankles are swelling up. He also had emphysema, so lung disease, bronchiectasis, this is a chronic lung problem, a high biopsy because he had this problem, and he's found amyloid in the various bits in the renal biopsy. Next one. This is typical amyloid, it stains red, sort of a pinky orange red depending on what your microscope setup is, with this dye called Congo red. Next one. Next one. So he had more blood work testing, and he had one of these monoclonal gammopathies in the blood, so a light chain in the blood that shouldn't be there. He had immunohistochemistry, and that's on. Had immunohistochemistry, special test to try and work out the type. And you can see it says equivocal here, and this is very commonly the result with these tests. They're not that good for amyloid. And so it was thought he could have AA amyloid, but maybe could it be AL because he's got a light chain circulating, or could it be one of the hereditary ones? So how could it be sorted out? Next one. So we did this test called tandem mass spectrometry, which proved in fact that he had serum, his deposits were composed of serum amyloid A2, and there's no other way to sort this issue out besides access to specialised testing. Next one. So I just thought I'd tell you quickly, just out of interest, what this technique is. So what happens when you have a tissue biopsy is that in it, it's not all amyloid, there's lots of normal structures of whatever organ that you've taken. So if you take a biopsy of the bone marrow, there might be a tiny little bit of amyloid, but lots of normal blood cells, there'll be bone, there'll be fat cells, all sorts of things in there. And the problem if you're trying to analyse the whole tissue is that the proteins in the amyloid get swamped by the proteins in the normal tissue. So what we do is this thing called laser capture microdissection. So this is a fancy technique where you look at the sample down a microscope and you dissect out with a laser just the amyloid deposits and leave all the rest of the tissue there. So when you've done that, this is about what you see. So here's a centimetre marker, millimetres things, and so this little thing there, that's the bit that's been dissected out. So it's pretty small, but it's much better than dissecting the whole tissue sample, which will often be, this big or sometimes this big. And then you do this fancy thing where you put it through this machine. So you dissect it out. Maybe we'll just skip through all of this. Keep going. Oh, actually, sorry, I'll just show you the pictures. Go back. So this was someone that we had. This was a gallbladder, I think. And this is a Congo red stain without what they call the normal stain, but you can see there's amyloid here in these blood vessels. So when we cut it out, just the next one, you can see that's been chopped out, and all this other stuff which doesn't have amyloid in it that would normally interfere with your analysis is gone. Next one. So all you're analysing is these little pieces of tissue, and these are like 1/10 of a millimetre in size. They're very small. Next one. Next one. Keep going. Keep going. Keep going. Keep going. So in the end, you put it through this machine and it tells you what proteins are in that sample that you've just analysed. And if you're in luck, which is about 95% of the time, it's got a pretty clear readout as to what amyloid protein is there. Next one. And just to show you about how difficult this is and how significant it is, I don't want to alarm you that people are making wrong decisions all the time, wrong diagnoses, but over the years you see a few of these things. He was a 60-year-old man who had undergone an autologous stem cell transplant, so that's pretty intensive therapy. 10 years previously for what was thought to be AL amyloidosis, so very appropriate therapy for that. But then he relapses and his sample comes to us. He never had AL amyloidosis. He never needed that transplant. Completely inappropriate. Another chap that came to us, only 65, so young, but he was actually having his stem cells collected to proceed to a transplant for AL amyloidosis. And in fact, his sample came back in the midst of his stem cell collection. And of course, he was transthyretin amyloidosis, completely inappropriate therapy. And so it illustrates, though, that it's difficult to make the diagnosis sometimes. So your doctors need to be aware of it. Next one. So the lesson is the key to correct management is to get the diagnosis right. Treatment differs according to the amyloid subtype, so you can't get it wrong. You can't get it wrong because chemotherapy and autotransplant, which are great for AL amyloidosis, are very deleterious to other forms of amyloid. Patients with ATTR, as we've just heard, need to be treated with transthyretin stablers or knockdown therapies, completely different types of treatment. You might need a kidney transplant for bridging amyloid, and secondary needs control of the underlying disease. So these are very significant and expensive, potentially toxic therapies. You've got to get the right one to the right person. Next one. So once you know you've got AL amyloidosis, you need to know all about the light chain that's causing the amyloid. You need to work out whether you've got the cancerous form or not, called myeloma, that can alter things, and you need to know where the amyloid is. Next one. So that means, next one, you've got to define the light chain and the clone that's making it, and that means these tests: serum protein electrophoresis, urine protein electrophoresis, serum-free light chain bone marrow plasmacytosis. But in particular, you need to know as a patient about your serum-free light chain. When we're trying to work out if treatment is working or not, all of these things are looked at, but this is the most important one, the serum-free light chain. Next one. Myeloma is a bone cancer which causes problems in the bone where it gets weak, can fracture, there are holes in your bones, so you need some sort of test of your bone, a scan, X-ray, MRI to work out if you've got bone disease. Myeloma causes the calcium to go up, you get anemic, got high numbers of plasma cells. So all those things need to be done just to make sure you don't have myeloma. Next one. And then you have to assess which organs are involved, which this is kind of the minimal thing. To assess the heart, you need an ECG. That's where you get the dots put on your chest and you see the little thing beeping up and down, which in the movie stops, and that's no good. You need an echocardiogram, and these two things, if you have AL amyloidosis with heart involvement, you must know these numbers, BNP and troponin, because these are the things we use to work out whether the heart involvement is worsening or improving. For the kidneys involvement, you need to know, are you losing protein in the urine? And that often involves a whole day collection of urine. You need your creatinine, that's otherwise a measure of your kidney function. In your liver, it's how big your liver is, and a liver blood test called ALP. Neuropathy is really based on symptoms rather than a particular test. We do have a test, but it's not terribly good for monitoring. Some patients have problems with their blood clotting system. Next one. And sometimes you need to do other tests depending on the situation. So some patients might need an MRI of the heart or some sort of monitor of their heart rhythm, nerve conduction test. They might need to have a look in the upper or lower bowel, just depending on what the presentation is. Next one. In terms of heart assessment, this is something that it's worth you knowing about. Traditional echocardiography, which is where you can see your heart beating on the screen, a little bit like the same technique with ultrasounds that you do to look at babies and pregnant women. So you can see your heart beating away. And there's been some innovations in that, particularly one that's called strain imaging. And if you've got heart involvement, this is TTR or AL, you should ask your cardiologist, do you have strain imaging? Because it is a far better technique. It's a quantum leap forward in terms of assessing your heart involvement. And it shows, you know, it uses a lot of fancy software, but amyloid's got a particular pattern on it, so it's very useful for diagnosing heart involvement. And there's parameters that change as treatment is working or not working that are useful. So that's something that's been developing in cardiology circles over the last 10 years. Over the next 10 years, I suspect all echo machines will have this strain imaging. Cardiac MRI is a very useful technique for diagnosing involvement of the heart, and sometimes you need that because the echo is not clear. Next one. These are these heart test markers that I mentioned to you about, this BNP and troponin, and there's a staging system based on these. And it splits people up into stage 1, 2 or 3. And you can see if you've got stage 1 disease, that is almost no heart involvement or no heart involvement. People here out at 60 months, so 5 years, pretty much everyone's alive with AL amyloidosis. Whereas if you've got advanced heart involvement, this down here, at 5 years, only about 25% of patients are alive. So having heart involvement in an AL amyloidosis is a very important predictor of how you're going to go. And to get that information, you need these markers, BNP and troponin. Next one. Here's a test we've been working on in Brisbane for a few years where we've been looking at PET scanning using things that are used in Alzheimer's disease. This Alzheimer's disease has got amyloid plaques in it, completely unrelated to these systemic forms of amyloidosis, not related in any way, but the structure of the material is similar. And so these things which bind to amyloid in dementia plaques in Alzheimer's disease, in fact, bind really well to amyloid elsewhere. And so you can see here in someone with AL amyloid, this is the heart here, you can see it lights up nicely. Transthyretin amyloid lights up easily. These were patients with severe hypertension. The heart doesn't light up at all. So it sort of looks like it might turn out to be a useful test. Next one. So how can we treat amyloidosis? This is a little bit similar to what Simon put up. You can do something to reduce the supply of the amyloid-forming protein. You can do something to try and stabilise the light chain-forming protein in the blood so it can't misfold. Or you can do something to try and get the amyloid out of the tissues. Next slide. So first, and this is still the only standard therapy proven in AL amyloidosis, you can give chemotherapy to kill the cells in the bone marrow that are making the light chain and thereby bring the light chain down. Next one. So the treatment principles in AL amyloidosis is to reduce this monoclonal production, as protein production, as profoundly and as quickly as you can. You want to aim for what they call a complete or very good partial responses. There's definitions of this, but you want to get that light chain down as far as you can, hopefully gone completely, and as quickly as possible. It's not that straightforward, however, because you have to tailor the therapy to the individual. And this relates to a couple of things. The treatments have different side effects, and so you can't use every treatment in every person. There are some drugs you can't use if the liver or kidneys are not working properly. It depends on the extent and degree of organ involvement. If you've got advanced heart involvement, it's too dangerous to do a transplant, for example. And a big issue for you in New Zealand and for us in Australia is availability of drugs. So you might hear all these things are useful, but you can't get hold of them unless you pay for it yourself, and that can be prohibitively expensive. And the other principle of treatment is you need organ-specific supportive care. Next one. So AL amyloidosis, there's no doubt now that the mainstay of treatment is this drug called bortezomib, otherwise known as Velcade. Commonly use these three drugs together: Velcade, cyclophosphamide, and dexamethasone. If you go to Canada, they call it Cybor-D, cyclophosphamide, bortezomib, dexamethasone. Or if you go to the UK, they call it CVD, cyclophosphamide, but we like to mix the initials around to make sure that no one knows what we're talking about. Some places use melphalan instead of cyclophosphamide, but it is based around this drug, bortezomib. Transplantation is being used less and less, I think, as time goes by because of the greater efficacy of some of these other treatments, but still can be useful. And there's lots of other drugs. These are drugs that we can access in Australia. New Zealand was the first country in the world, and still one of the only, where bortezomib is actually approved for AL amyloidosis. They sort of got it through Dr. Goodman, in fact, which got appended to a myeloma application for bortezomib. So he added in the words "and AL amyloidosis," and it stuck through Pharmac. No other country in the world had that approved until just recently in the US when they got Velcade approved. So in Australia, we can't access, we have no drug approved for amyloidosis. We can only access it by saying every patient has myeloma. So every AL patient of mine with amyloidosis has myeloma, even though they don't really have it. That's the only way to get the drugs. So all of these are in Australia, and some of them in New Zealand approved for myeloma. And you just get what you can get access to. But the point here is, I guess there are multiple options. There are a number of things you can cycle patients through if the initial treatment doesn't work. Next one. So we participated in this trial. There's a collaboration between us and the Europeans to look at whether bortezomib really works or not. Next one. And this was a trial where half of the patient got the traditional treatment, which 12 years ago used to be melphalan and dexamethasone, two common drugs, and the other half got bortezomib as well. And this is a graph of how many people are alive, and you can see the red line, those that got bortezomib, more patients alive than those that didn't. And so bortezomib is, on the basis of this study, the standard treatment for upfront of AL amyloidosis. Next one. This trial's just recently been published, which was looking at a new drug called daratumumab, an antibody against something on the surface of plasma cells, very good at killing it. And it looked at Velcade-based treatment with or without that daratumumab. So half the patients got just the 6 months of Velcade-based treatment, half got the same treatment but with daratumumab on top. Next one. And this was certainly very exciting results, but as of currently, only approved in the US in the world in terms of regulatory approval. Probably not in Australia for a couple of years, I imagine, but we'll see how we go. New Zealand, I don't know. But this is how many patients achieved a complete response. That is, you could not detect the light chain at all on our current testing. This is what you want to achieve. And you can see it went from 19% to 59%. So very good at getting rid of the light chain. But what you want in amyloidosis is not just to get the light chain down, you want to get the organs better. Next slide. And this trial was very pleasing. This is 6 months follow-up, and this was 12 months follow-up. That essentially I've got telling the wrong thing. This is heart at 12 months follow-up, and this is kidney. So if you have the daratumumab, the purple bar, basically double the improvement in kidney involvement, double the improvement in cardiac involvement if you get the daratumumab. So there's no doubt that the combination of bortezomib with this new drug daratumumab will become the standard treatment. It is now in the US, and I guess as it gets through the regulatory processes, it will be in other places in the world. Next one. Autotransplantation, I won't say too much about it. This is a way to deliver a very high dose of chemotherapy to try and completely wipe out the clone. It's got good response rates, although its response rates are not as good as in the trial I just showed you. So it'll be used less and less, I think, but there is lots of long-term outcome data. It's been used for a long time. It's still got a role in patients. Next one. Next one. The last thing I'll just talk about is immunotherapy. Next slide. So there's previously been attempts at trying to get amyloid out of the tissues quickly, because that's what's causing people to be unwell and have symptoms. And in the case of amyloid in your heart, that's what's life-threatening, particularly in AL amyloidosis, where the cardiac involvement is so much more dramatic than in transthyretin. It moves much more quickly. So what you'd like to do is just get that protein out fast. And the problem is your immune system does not recognize it very well. Your immune system should be able to get rid of foreign protein, but perhaps because it's your own protein that's misfolded, it doesn't recognize it very well. So this is an antibody which has been designed to bind onto amyloid in the tissues, but not onto the circulating light chain or the plasma cells, and tell your immune system, here's the amyloid, come and eat it up. Next one. So this trial has just started around the world, and half the patients will get that VCD chemotherapy, and half the patients will get that with this new antibody to see if it really does bring the amyloid out more quickly. This drug antibody has been shown to be safe. It's been given to a number of amyloid patients without side effects, and it's got some hints of working. It certainly works well in a mouse in a test tube, but whether it really works in patients with amyloidosis, this trial will tell us. Next one. So this is kind of, Simon and I wrote these guidelines for Australia. This is kind of our approach. Everyone starts with bortezomib-based treatment, but what happens depends on how good the response is in bringing down those light chains. So I'll just show a couple of things. If your response is really good, what they call a complete response, we can't detect the light chain at all we do is finish off that chemotherapy treatment with that Velcade, nothing more. On the other hand, if it is not coming down enough after 2 or 3 cycles, you don't stay on the treatment for 6 months, you switch. You've got to find something that works, that brings the light chains down. Because if the light chains don't come down, that amyloid is not going to have a chance to come out of the organs. So you don't want to be staying on ineffective therapy. Next one. Just a couple of words on monitoring, and then I'll finish up. So you have to monitor the progress with assessments of the amyloid forming free light chain, which could be kappa or lambda, depending on what you've got. You've got to measure these cardiac biomarkers because of all the organs that can be involved. The heart's the most critical, so you certainly want to know about that. If the light chains are coming down, the treatment's working, you want about a 90% reduction. There are strict definitions about these things, which I won't go into, but you want to see it coming down a lot. We've certainly got far more options than 5 years ago. The treatment field has really changed a lot. It's improved. Next slide. Besides the light chain, you'll want to also be having measurements of your organ function. So that can include these biomarkers, but an echo every now and again, urine tests and blood tests for the kidneys, liver tests and feeling the liver or a scan for your liver, nerves based on symptoms. Next one. Yeah, just keep going. I think we'll... do you want me to talk about secondary amyloid? There's no one here with it, so... Or online, I guess, maybe there could be. So maybe I'll just quickly go through secondary amyloid. Next one. I've only got a few slides. So it used to be called secondary amyloid, now it's AA amyloidosis because the protein is serum amyloid A protein. Next one. So these are amyloid fibrils that derive from the serum amyloid protein, which is produced when your body has inflammation. That inflammation can be due to an inflammatory arthritis, could be an inherited problem, could be inflammation due to a slow-growing cancer or a chronic infection. So in fact, the inflammation has to be going for a long time. In fact, in the UK series, an average of 17 years of some sort of inflammatory disease before patients develop amyloidosis of this type. Nearly always involves the kidneys, which causes loss of protein in the kidneys. Kidneys don't work as well. Less common in the liver, the adrenal glands, very uncommon to be in the heart, extremely uncommon to affect the nerves. Next one. Next one. So these are the diseases that patients can have that are causing the production of this long-term elevated serum amyloid A protein. So rheumatoid arthritis, very common underlying cause. It's becoming really uncommon in the Western world, secondary amyloidosis, because control of arthritis and control of chronic infections are problems of the third world now. The treatments we've got in the West for both of those things are very good. So, in fact, what we do see is we see problems with intravenous drug users who get chronic infections in their skin from where talc and stuff that they've been injecting just causes chronic lumps and infection. We've got 2 of these in our clinic. Tuberculosis, I mean, we just don't see that, but in some parts of the world it's still very common. There's some inherited problems where you get high inflammation all the time. It's uncommon to have these other sort of chronic infections. So it's becoming very uncommon of all the amyloids, but it's still around. Next one. Next one. So what do you do about it? In fact, you have to treat the underlying disease. And if you can reduce this serum amyloid A protein down to low levels, or if you can't measure it, because a lot of places don't have that test, you can measure a much more common test that's available in every laboratory called the C-reactive protein. You get that down as low as possible, and as with every type of amyloid, and demonstrated recently by Patisseran, if you can get the amyloid forming protein down low enough, you can actually get stabilization, you can get improvement with amyloid coming out of the tissues. And the same is with AA amyloidosis. There is a drug that's been developed to interfere with deposition of the fibrils, and the initial trial showed some slowing of renal deterioration, but didn't prevent patients progressing to needing dialysis, so not that effective, and supportive care is very important. Next one. So I think that might be it. Yeah, that's all. So maybe, is Simon online? Maybe Simon and I, any questions from anyone about anything? Yeah.
I could start. As you know, we don't have any multidisciplinary clinic to deal with amyloidosis patients in New Zealand. I just wondered what the prospects might be of Australian clinics accepting New Zealand patients.
Did you hear that, Simon?
I did. It's a great question. It all depends on when Jacinda opens the borders to us dirty Melburnians. I would love to be over there. Look, I think one of the things that I think the Australian Amyloidosis Network's tried to do is work closely with New Zealand specialists. I think initially what we really tried to do is to highlight to pharmaceutical companies that there is this wonderful country called New Zealand, and that New Zealand is excellent to experiment on. I mean, no. In all seriousness, I think that the first thing we want to do is to get clinical trials into the country, and I think that I think Hugh Goodman and Tim Sutton and Ed Gain have been fantastic, along with the patient network people, and because I think that helps to raise the awareness and just to let everyone know that we are here and we're happy to be consulted. But I think in terms of actually going over there, that's logistically going to be a bit tricky. But we're very, very happy to help in any way. I don't know whether Peter has anything to add to that.
So it's a big deal to leave your country to get a medical opinion. Particularly, I guess, in this day where you can do teleconsultations and all sorts of stuff, but you need expertise in New Zealand. You can't make someone interested in amyloidosis. You have to have clinicians that are willing to set that up and take that on. So in fact, for example, in Australia, the first clinic was in Sydney, and then in Brisbane. And we had to wait, I think, 5 years before someone came to Melbourne, which was Simon. So Melbourne was a very difficult area for us until Simon came, because everyone was an amyloid expert. It's probably different to New Zealand. In Australia, every haematologist is an expert in amyloidosis. And so it was very difficult to get good advice into Melbourne. And similarly, we had problems with Perth because we had no one there, but then a doctor who had spent 2 years in the amyloid centre at the Mayo Clinic returned to Perth, and he was obviously keen as beans. And so all of our centres have been set up around doctors who've come back, and one of them is a champion of the disease and willing to take that forward. Because you've got to educate yourself. It's not knowledge that you acquire often just in your general training. You have to have had some exposure at some point. So that's one thing. The other thing is that there are different models of clinics. So like our clinic is, a physical clinic where people come in, there's cardiologist, renal physician in the room next door, whatever. But there are a number of specialty clinics in rare diseases around the world which are virtual. Maybe this is something that will work for New Zealand. And that needs, again, it just needs people to be interested enough to set aside a particular time and hopefully have some organisational capacity to make the clinic work. None of our clinics have got any funding from government or institutions. It's sort of been in kind, sort of support. But that's all you need to get going. So there are different models. I don't know what would be the best. I mean, a number of patients I know from New Zealand, I've seen a few, so I haven't seen a bucket load, but that is not the future for amyloid care in New Zealand. That's like a stopgap measure. Yeah.
The haematologist professional organisation is, as I understand it, Australasian, covers both New Zealand and Australia. Is there a lot of cross-fertilisation, if you like, with knowledge through that association, or is amyloidosis too minor to really register?
I'll answer that one, Simon. So look, we had a number of strategic directions we took in Australia a number of years ago, and one of them was to introduce amyloidosis into every specialty conference that we could. And haematology was the first. So since 2007, so that's a long time now, there's been an amyloidosis talk at every haematology meeting. So that was easy because we're haematologists, we can infiltrate it. And we've done that. That's been in the Cardiology Society of Australia and New Zealand's annual meeting as a distinct session for the last 4 years, I think now. There is a lot of professional sort of interaction. I chair the Australasian Leukemia and Lymphoma Group, which is our trials network, which incorporates amyloidosis. And we've spent the last couple of years fairly vigorously lobbying the New Zealand government on behalf of our New Zealand members to improve things around drug access. I don't know that we've had a lot of success, but I know what will happen if we do nothing, which is nothing will happen. And in fact, just before Christmas, we wrote, our group wrote a letter, and in fact 15 other trial groups in New Zealand joined that letter to the health department to try and see if some of these issues could be addressed. It's all being confused at the moment by the, dismissal of the district health system in New Zealand. So I certainly don't know, but none of my New Zealand colleagues seem to know exactly how that's going to pan out. But maybe that'll be an opportunity to get some of these issues sorted if you've got, one payer. So yes, there is a lot of interaction. I would say if someone doesn't try to stick up for New Zealand, they will, I would say, generally get lost in the scheme of things. So you need to have your New Zealand members banging on the door all the time to make sure these things kept at the forefront of everyone's attention. Sorry, long answer. Any other questions?
Got a more technical one. Is there any evidence that in TTR wild type that the monomer misfolds before it forms part of a tetramer?
Oh, Simon.
Was the question, was there any evidence that there's a monomer and then it forms a tetramer?
Yeah, well, the monomeric form actually undergoes the misfolding rather than somehow when it's in a more stable tetramer that it somehow falls apart. It seems to me that we might have things backwards, but the evidence is the evidence.
I didn't quite catch it, but I gather that the question is it that the monomers are just produced and they don't form the tetramers?
That they misfold and therefore they do not form tetramers. They misfold as monomers.
That's possible. I'm not aware. I haven't actually seen any data about that, but it makes a lot of sense. I think proteins. My understanding is that the transthyretin, likes being in a four-leaf clover tetramer type pattern, and I would suspect that there's a lot of there is some leaching out of monomers, chronically. I think what you need is enough of them to start to kink together and aggregate together to form a template, and once you've actually laid down some amyloid, it will continue to build. And I think it takes quite some time for that to happen. So I don't know if I've really answered your question. I guess the short answer is I don't know.
That's fair enough. Is there any data on?
I'll answer that one. Sorry, before you say. My understanding, I'm not a structural chemist. My understanding is that the hepatocyte, the liver functioning cell, makes the monomers and they assemble prior to secretion in the hepatocyte. And so you're actually it's not making monomers which then join together in the blood. So the secreted product is a tetramer and then it falls apart. So I don't know whether you make, like the light change, some monomers escape out. I don't know about those tissues, but I don't think there's an opportunity for misfolding in the blood because it's secreted as the tetramer.
Or misfolding within the cell and then being secreted as monomeric forms.
Yeah, I don't know about that.
Any evidence for post-transcriptional, post-translational modification?
I don't know the answer to that one. That's
Middle age have higher levels of transthyretin than women, which may account for why wild type is mainly seen in men. I suspect that women will all develop transthyretin amyloidosis as well if they live long enough. I've certainly got a couple of female patients in their late 80s and 90s with wild type. But in terms of, it's actually, transthyretin is actually a negative phase reactant. So you have, acute phase reactants like, ferritin. We see that will go up if you have inflammation. If you have inflammation, then transthyretin levels actually go down. Apparently, again, I don't have much data on that. So. Which surprises me because I would have thought if you were inflamed, that might account for why we get transthyretin depositing in places like the carpal tunnel, which is used a lot, and in the heart. We also know that patients who have been elite athletes in their youths are probably more likely to develop amyloid a little bit earlier, transthyretin amyloidosis. So I've got a lot of ex-footballers and people who have had manual jobs, farmers, bricklayers, those sorts of people, but I'm not aware that transthyretin levels will increase or change depending on other disease states.
Yep.
Can I just ask about transthyretin stability? I mean, wild type is a disease of older men. Is it likely that the stability of the TTR molecule has changed as people get older? Or is it likely that it's always been unstable but doesn't actually present clinically until several decades have passed, for instance? Is it likely to be something that we're born with, or is it likely to be something that becomes more unstable with age?
I don't think we know the answer to that. I mean, I think that we know transthyretin is an inherently amyloidogenic protein. It's a protein that can dissociate into amyloidogenic monomers, and that I don't know whether it's just a build-up over time or whether that actually increases with age. I suspect the latter, but I don't know any data. But it's a good question. So you've given me food for thought. I need to go away and have a look. It's amazing what strikes me about transthyretin amyloidosis. Like if you go back, when I was in London at the National Amyloidosis Centre back 12, 15 years ago, we would see, for the whole of the UK, we would see a handful of patients in the clinic a week. In Melbourne now, we've usually got about 10 patients in the clinic, and we get a new referral every week. So I think we've learned a huge amount about transthyretin amyloidosis, but there's still these sort of really basic unanswered questions that we don't know, or are certainly not well known. I don't know whether you know, Peter.
No, there's obviously other factors. I mean, Simon's mentioned the mark, sex predisposition. And so that's referring to difference in enough amyloid deposition to cause organ impairment. Because if you look at the autopsy series of 100-year-olds, 90-year-olds, males and females have the same amount of, they've both got the same amount of amyloid deposition. Not same amount, but they both got amyloid depositions affecting equal numbers. But other factors have got to be involved, because we've all got transthyretin, we're all making it at roughly similar levels. I know Simon said males in their middle age have higher levels, but I think it's more than that. Mentioned the elite athlete thing, but I've heard this theory a number of times, and I've often thought of it myself, is that the amyloid seems to deposit in areas of high movement, your heart, constant movement, your wrists, your lower back, your biceps tendon, all these places that are subject to repetitive movement. So whether that's, I don't know, inflammation, but maybe stress, so that maybe some sort of physical stress on the protein leads it. But is it something, so what's the issue with women? Is it something to do with estrogen affecting transcription of other genes that produce something that makes transthyretin more likely to misfold? Is it the expression of something in the tissues that's the target for transthyretin? It likes to bind to, there's a variety of things, receptors for advanced glycation end products that might be something like that that's the target. So, I don't know, and I haven't read anything that's sorted out that issue, but there's no doubt that a 5-year-old's transthyretin is amyloidogenic. It's the same molecule. Any other questions? We've had more biochemistry in this talk than I've had for
Yes.
Does having TTR amyloidosis completely rule out chemotherapy in the event of cancer?
Short answer, no. Simon?
I didn't hear the question.
Does having transthyretin amyloidosis rule out chemotherapy if you develop another cancer?
No.
That would be...
like everything, you have to be, if you develop another cancer, you have to have an assessment as to whether someone is fit for chemotherapy. Now, if you've got very mild transthyretin amyloidosis, you've got a little bit of shortness of breath, but actually your exercise tolerance is pretty good, you can still do most things, then, mild to moderate chemotherapy would be very much appropriate. If you are struggling to walk 10 meters and you've got uncontrolled fluid retention, then it's going to be very difficult to deliver any meaningful chemotherapy for another cancer. So the answer, my initial reaction is no, but everything comes with a qualification.
Was that your question? Yes. So I think there's nothing specific about transthyretin compared to any other cause of heart trouble. It would just have to be assessed on the merits of whether the chemotherapy could be delivered given that cardiac function. Some chemotherapy agents, for example, are cardiotoxic, and you'd be nervous about giving a cardiotoxic drug to someone who's got a poor functioning heart, but a mild one might be okay. So. Any other questions? Yeah. Okay.
What role, if any, do we as caregivers and patients have in keeping the trials open or even coming to New Zealand? My father has wild-type amyloidosis. Patisseran. There was ethical approval completed here by a cardiologist and his team, ready to be up and running by the end of May, and had the news from him that he was very disappointed that New Zealand was not part of the trial. 22 other countries are. So I'm just asking, as a caregiver or a patient, do we have any role in making any difference?
Shall I have a crack at that one, Simon? Talking about the role of...
I heard something about caregiving and Patisseran.
The role of patients and carers in trying to make sure trials come to be available. So I guess, there's multiple levels to that question. Yes is the answer. Can you always get the results you want? No. I mean, we had in Australia, we had lined up the Interterson trials. We in fact had ethics as well, and the company just pulled the trial in Australia. Not worldwide, just in Australia. And we had a similar one with Patisseran recently for the hereditary amyloid patients where, we'd consented all these patients, they signed the consent form to start, and they just decided to stop the trial early because it was looking so good. And so that is absolutely unethical. But, these are commercial companies. They make decisions based on commercial factors, not because they're benevolent organisations. And we see this all the time with trials. And so this is a group, for us, a relatively well organised, internationally connected group of doctors in the amyloid space, still couldn't overcome this company resources. We forced some compromise for them, but you can't always get the outcome you want. But what can patients do? I mean, look at this meeting for one. That's one thing that is building awareness, that's starting to get the messages to doctors who might be interested. They know the patients are there. Some patients take things or carers take things a step further. So Jamie, for example, we've got our equivalents in Australia who meet directly with the companies and chase them. Or if you're absolutely full of energy, you could be someone like Isabel Losada, who's, off the back of her own energy, set up an international group, met with the FDA to get endpoints appropriate for trials, brought doctors together. So, that's anywhere from just supporting your partner who has amyloidosis to trying to change the world and succeeding to some extent. So, yes, wherever you want to go and what your skill set is, I don't think there's really it can't be done.
I think
You go.
I didn't initially hear the question, but I think it was what role do caregivers have for attracting clinical trials? Was that it?
Yep.
Yeah, it's a good question and a tricky one. I mean, I think Peter was right. There's lots of things to unpack, because I think part of it is, the carer's role and how you can help, and access to clinical trials and novel agents in Australia and New Zealand. So one of the reasons why we set up the AN was so we could get together and have a more coordinated approach at sort of lobbying pharma, lobbying government. I definitely think that making government aware of amyloidosis and the rarity, that sort of stuff never is lost. I think raising awareness is always really important. I think keeping in conversation with the AAN and encouraging your specialists, if you've heard of a trial and they haven't, encouraging them to think about opening it. The closure of trials is very difficult, and my sort of feeling is that if there is a trial that's open in New Zealand, then the doctors, we have to go through the protocols and make sure that we feel that it's ethical, because we're not going to put it through an ethics committee until we're happy to recruit patients to it, number one. And then the ethics committees go over things with a very fine tooth comb. So if your doctor is saying, we think this would be a great drug or this would be a great trial, I'd encourage you to consider going on it as soon as possible, because we've had this issue, I think, almost with every trial we've had recently. Though amyloidosis is becoming increasingly known about, and all the trials are closing early, which is very frustrating, because we'd like to get as many patients on there as possible. But I think we have a clinical trials page on the amyloidosis website, which we update regularly. And we will continue to do so. So for New Zealand, I'm always, telling pharma they should seriously consider running their trials in New Zealand, because I know that access is an issue like with Australia.
Our website is essentially run by a carer. So we'll put the effort in, it wouldn't have happened without her. Sorry, yeah.
Would it be useful for New Zealand and Australia to start a conversation about joining forces? Well, we don't have a clinical rule here, and you have 4 or 5 now, so you've got professionals that have a passion for it, and we've got ours over here, but they're very few. And you also know how to set up the systems now, and I just wonder whether it would be beneficial to do that, more power. We're better to get.
Gives us. We probably don't need that right now, but we're thinking in 10 years we probably will need that. With the wrong.
I've got Professor Gall this evening, and he will present as well. Just all these people involved, I think, is huge. And so bit by bit, we will get somewhere. I think so. Don't be discouraged. That's what I'm trying to say. Clinical trials. Something that I've learned is that pharmaceutical companies they need to hear our voice. We didn't start this, I think, if we didn't, my husband and I, when he was quite ill at that point in time, but we had to make that trip over to Berlin, because that was where the amyloidosis conference worldwide was happening. And it was there that
now, and
going to Berlin was eye-opener, seeing how different governments were doing it, different pharmaceutical companies were doing it, and which is more patient-focused than the clinician side of it. And there's an ethical reason why they do that. And we were able to sort of meet a lot of the global people representing the drug company that discussed that. and they willingly walk us through what we needed to do to get trials in, and give us advice, give us resources, and so forth. I think that's important, getting started to do something rather than doing nothing, and then getting local support. MPs or clinicians, it helps a lot of that as well. And if you said that nothing expect nothing to happen to you, you won't, because it's nothing happened. So if you can set a precedent of getting gene silence into the country, others will be keen as well. I mean, when Simon heard I was getting a treatment, he said, "Can he get out?" I connected him to the person that helped us, and she said, "Yeah, we'll help with that." I think that's a collaboration that's between the patient and the clinician. We just can't expect the clinicians to just be doing all the work. We as patient and carers, we've got to step in as well. And I think Jamie's hinted this many times, is you've got to be responsible for your care, your well-being, and be aware of what's going on. And we aim to do that. And we as a group, while the clinicians are tying together, we as an association are tying with the UK group, with the US, Australia, Korea, and Europe as well. And that makes us bigger known. So when they hear something, they let us know. When we hear something, we let them know. And so we constantly update. And we would love more people to get involved and chip in, because ultimately you drive your care, especially in New Zealand.
Just wanted to hear your advice in terms of, say, us in New Zealand, and if we wanted to think about our next steps with limited resources that we have, and the various drugs that are out there globally. Would you advise paying particular effort or focus towards any specific drug that we should try and sort of lobby for New Zealand and Australia, or would you advise, just going out for all of them, whichever ones are out there? Is there any one particular that you think that, where your chances are, our chances would be higher?
Right. For AL amyloidosis, you should focus on getting daratumumab. And that might actually be possible in New Zealand. The reason for that, it's an expensive drug, but it's time limited. A lot of treatments go on for ages and they become unaffordable to governments. But amyloidosis, it's time limited. You've already got Velcade approved, so maybe that would be. In the TTR space, at the moment, if I had a choice in Australia, I'd be trying to get one of the knockdown therapies as expensive, but might actually change the course of the disease. Tafamidis just slows it down. So,
yeah, I totally agree.
But I was saying this when we had dinner last night. We have been in touch with these companies numerous times for the last 5 years, and a lot of promises about coming to Australia with these drugs, but still not there. And why is that the case? Because they work out, they're very keen to get out of you, how many patients do you have in your country? And they find out, and it's not many. And so, even though we're a rich country in terms of world countries, we don't have a lot of patients, so we just have been knocked down and down and down. Both companies, countries of, so they haven't even started the process in Australia yet. So that's discouraging. But I think they're the drugs that have got the most bang for the buck.
Just
so Simon, do you?
As a point of
No, I think you've answered it very well. I would agree. I think that daratumumab is an extraordinary drug, and the other good thing about daratumumab is that it either works or it doesn't, pretty much. So we know that if you haven't had a response after a month, it's not going to work, pretty much. So that's I think a big bonus. Velcade is you can get in New Zealand, which is great. So I think Darren made the nail, and I would agree with Peter. I mean, you can access diflunisal, which is basically tafamidis with side effects, and not everyone gets the side effects. So, but I think that a gene silencer, that's going to be the difference. And I think the real holy grail will be, I think that if you combine a silencer with a stabilizer, the disease would just stop. But that's so I think that diflunisal will still have a role to play for quite some time, because I don't think we'll be able to afford a silencer and tafamidis. But if you just go for tafamidis, then you've got no silencer. So I would definitely suggest going for a silencer. And I know that we've been in contact with Alnylam, and we're very keen to be involved in trials and to get compassionate access, if at all possible, in both countries. But ultimately, they're interested in getting it licensed and reimbursed by the government. And so I think that my money would be on a silencer, and I think we're probably more advanced with speaking with the Alnylam team with Patisseran or Vutisseran, which is the longer acting injection in the stomach, which I think will be a lot more easy to administer.
Sorry,
No, I was just going to say that daratumumab is available in New Zealand, but only privately.
Yeah, I mean, that's the same in Australia. I mean, most countries, if you want to pay for it, you can get any drug into the country.
Yeah.
I've
had a couple of patients who, I've said I really, although it's very expensive, I think, because they had very, very advanced disease and it was looking very serious indeed, that, some of them had paid for a couple of infusions just to see if we could turn the tap off. So we have done that, but it's not available for everyone, unfortunately, that sort of thing.
I mean, the end game with drugs, and it's the same in New Zealand as in Australia, is get the drug available for everyone, no matter where they live, no matter whether they're rich or poor, who they are, they can get the drug. And in Australia, that's to get it on what we call the PBS, which is government funded. I don't actually know what your drug list is called, but whatever's administered by Pharmac. That's the end game. And until you've got there, you can't be happy. Yeah.
I can say that we are lobbying. We are working hard to try and get drugs, licensed and reimbursed, but it takes a frustratingly long period of time. We need pharma on board. So, in terms of carers and doing things, pressuring pharma to bring the drugs, but ultimately it's going to be a business decision.
Do either of your clinics have a
Complicated because we've got a cut-off depending on the age as to whether you can have AstraZeneca or not. But yes, we're telling everyone, yes, you should get vaccinated, and yes, you should get it now. Although it's not actually available for everyone. Same as New Zealand, there's a rollout sort of thing. But yes, I'm personally not optimistic that we'll be able to hold out COVID with border protection for another year. A lot of countries did very well and have had enormous outbreaks. We've had a couple in Australia that are significant, and I think the solution is that we have to get the population vaccinated. But there's a little bit of uncertainty, particularly in Australia because of these rare clots that occur with the AstraZeneca vaccine.
So, Peter, can I say? So if you look at the website, you can see where people are going to be able to get their vaccine. And we've already know that next month is for people with comorbid conditions, and we've arranged, for example, for all our transplant recipients to be contacted by the local regional public health. Because at this stage, with the Pfizer vaccine, you have to go to the regional hubs for the vaccination. And you've probably heard recently that it may be that the Pfizer vaccine will be stable in the fridge for 21 days, which in case I think we'll start to see GPs vaccinated. But that's not happening yet.
There's a list of GPs that are doing it now, came out last
But,
week.
but it may even be more widespread. If you keep your COVID vaccine in the fridge for 21 days, you can vaccinate everyone in your practice. But I think anyone with amyloidosis should be considered in that next tranche of people with comorbidity. And I think it's important that you do speak to your specialist or GP. Well, we've already got about 800 liver transplant recipients waiting to get called in next month.
Yeah, I think it is important. I don't know whether there's much vaccine hesitancy in New Zealand, but there is a bit in Australia. Like Victoria's recent outbreak, vaccination rates, all of a sudden it becomes real to people again. And I just wish people in Australia would just get vaccinated. But anyway.
The demand for vaccination in Melbourne has absolutely skyrocketed. You just need a lockdown to focus the mind. It's not pleasant, it's not fun for everyone, and I think that we had an extended period last year when we were in lockdown. We had a curfew for 6 weeks where everyone had to be inside their homes by 8 p.m. and we couldn't leave until 5 a.m. It was, it was really, really tough going psychologically. If New Zealand gets an outbreak, that the same thing's going to happen, and it's, you want to try and avoid that if you can. And I think that the vaccines appear to be remarkably effective and well tolerated. I think that the clotting issue with AstraZeneca is a non-starter, to be honest. It's still extremely rare. So I would definitely encourage as many people as possible to get vaccinated, and then we can hopefully get back to some sort of normality. But as I sit here in lockdown, I would encourage you all to go and get vaccinated.
Thank you, Dr. Mollee. Thank you, everyone, for this evening. We have an early start tomorrow at 9:30. Don't worry, you'll have lots of opportunities to continue asking questions. So for now, thank you to the online viewers as well for tuning in. So we'll see all of you bright and early tomorrow morning. Thank you.